Good afternoon, everyone. Um, this is Cindy from the PRC. In case I think you can see me, you just can't see the screen. In our outlying areas, in our really, it looks like we had a good turnout today for our outlying areas. We're just waiting on Dr. Aldred. He does see patients today, and so he just might be a couple minutes behind. So stick in there for me, and we'll let you know as soon as we can when we're going to start. And enjoy. And what?
He's on the way in a few minutes.
Okay, so it sounds we just talked to him, and it sounds like he's just a couple minutes away. So thank you for your patience.
Cindy, the summit in September, where is it going to be?
The summit, the information that was up on the board, the summit is going to be at the Northern Quest Resort, where it was last year. In fact, we're going to try and do maybe a little bit longer event, not the day of, but we're going to try and combine some things. We're going to try and have a support group leader training on the Friday before at the PRC, and then maybe I'll get together the Friday night and a summit to make it a nice weekend event. But you don't have to go to all of them, so we're excited. But yeah, mark your calendars. And Spokane Airway Heights. Not currently, because there's a couple places that have asked, like Fairwood, or some of those that have asked about getting a location, and we just haven't gotten a chance to see what it takes to get it set up inside of something that's not connected to a clinic or something like that. But we have it in a library in Pendleton, so he doesn't necessarily need to be in a clinic or a hospital. So is he? Is he there? I'm getting feedback that he's around the corner. Woo! Well, that's what I'm trying to do right now, actually. Well, I'm trying. The internet is kind of here, so.
Okay. Well, either that or I can transfer it over to USB.
Yeah, actually, you can put a USB right into the.
Do you have a memory key?
I do.
Just in case.
I'm kind of trying to be ready to go. So Mike, I tried to log in and.
Excuse me, but Pendleton cannot hear anything. Did somebody step on a cord?
Hi, Pendleton. No, I think we're just getting the presentation ready to go, and they'll open their mic here in just a moment.
Thank you so much.
Yeah, we'll get right back to you as soon as we get the PowerPoint turned on here.
St. Luke's doesn't have HDMI.
Since we want to get right into the presentation today, I'm not going to spend a lot of time on an introduction because Dr. Aldred will actually be doing some of the introduction himself about programs and things that he works on. And things that are going on. I'm going to have everybody in our outlying areas go ahead and mute their mic. You will hear Dr. Aldred taking some questions here in the audience in Spokane, but at the end of his presentation, he will open up, or we'll ask you to open up the mic, and then we'll do our normal round robin of questions at the end. But thank you, everybody, for joining us today. Hopefully you are enjoying the beautiful weather wherever you are at, and whether you have snow, rain, or sunshine. And welcome, Dr. Aldred.
Thanks, everybody. Can you hear me okay here, I guess? We have the speakers here, and the far end people can let us know if they have issues. Okay. Well, I'm very happy to be here to talk about the, some newly released anti-Parkinson's medication, kind of put it in perspective where this fits with the current therapies that are currently being used to treat Parkinson's disease, and talk a little bit, as time permits, about upcoming medications that aren't yet released. We'll have a lot of time for questions. I'll kind of see how things are going, and I may cut off some of the other slides for things that aren't quite yet happening. So just a quick bit about me, then we'll get into the content. I'm a movement disorders Parkinson's neurologist here, fellowship trained. Did my neurology residency and 2 years of Parkinson's fellowship training at OHSU. Missed being in the Northwest after being away for 5 years, so I moved back out here to Spokane in April. Joined a Parkinson's clinic that's been known for many years, Northwest Neurological, developing our Inland Northwest Parkinson Center, which is a collaboration between our practice, the Inland Neurosurgery, Sacred Heart Medical Center, and actually now with St. Luke's having some research collaboration as well, starting as of last week. So very happy to be here with these people in place. These other professionals are one of the main reasons I came out here. There's such a long history of Parkinson's specialty care in Spokane. I wanted to be part of that, and been very pleased being here so far. Don't have to tell this group what movement disorders are, but of course, Parkinson's is kind of the hallmark movement disorder. There's many other movement disorders such as essential tremor, other unusual gait disorders, mimics of Parkinson's disease, Tourette syndrome, etc. Just a bit about the kind of treatments that we do as movement disorders specialists in our center: medication management, education, coaxing those out there who don't exercise enough to exercise more. We do Botox injections, cognitive imbalance testing as well, and also we're starting telemedicine in Eastern Washington hopefully as of April, we think. So we've got a very broad clinic with lots of areas of care. And then research, I'm involved right now. We're the largest recruiting site for Connect Parkinson's, which is a randomized controlled trial for telemedicine for Parkinson's disease in Washington State, Iowa, Minnesota, and Wisconsin, where I have licenses. And then later this fall, maybe into next winter, we'll start an NIH trial using a medicine called inosine to possibly slow the progression of Parkinson's. And we're actually meeting later today to talk about starting a new trial doing a sleep DBS, which may be a possibility here in Spokane in the near future. So lots of exciting things going on through the Inland Northwest Parkinson Center collaboration. There we go. And why do we do all this? What's it for? Well, as most of you know, there's no cure for Parkinson's yet. There will be, just not yet. So until then, the whole point of all this stuff, like what's it going to do? Well, everything's supposed to improve your quality of life and maintain your independence. You live the life that you want to live. Don't let down the guards for other things like cancer, stroke, and all those other things, because Parkinson's is not going to get you. We're going to try to keep that at bay, and then make that anything else that you can live with, to go on and have a good quality of life. So just a quick overview of Parkinson's disease. Parkinson's is a movement disorder, largely. Tremor, slow movement, stiffness, one side of the body more than the other initially, though over time, Parkinson's progresses. It's this progression that's really the biggest fear most people have. What will happen to me? What's going to happen to my movement, my mobility? How will I have to rely on others to do things for me down the road? This is the last thing I wanted, at this point. And that's the big fear in Parkinson's, is the progression over time. knowing that at one point there were very limited to no options, to limited options to treat Parkinson's disease, to the point now where we have all sorts of things from, knowing that actually exercise is more than just for heart and lungs, but it actually treats Parkinson's, all the way to brain stimulation, which has been a game changer, to now even newer therapies like the Levodopa pump, which we'll talk about today. Knowing that there's all these treatments around to treat movement symptoms at least gives us hope. Knowing about these treatments, to being educated, to know which treatment is the right treatment for you at the right time, what's over the top, what's the right time for this. That's a big part of living well with Parkinson's. So the movement symptoms of Parkinson's are related to underlying neurodegenerative changes in the brain. Specifically on the left side of the screen, you'll see the stoop posture, slow movement, stiffness, tremor. And on the right side of the screen, you'll see this pinkish color with this arrow pointed to a circular round structure called a Lewy body that's in dopamine-producing cells in the middle of the brain. When those cells are low in a critical amount, and they've actually been decreasing over time, but when they're significantly low, that's when the movement symptoms of Parkinson's first begin. So there have been changes going on for years, perhaps even longer. Changes associated with poor sense of smell, acting out dreams, other symptoms we're not going to get into today called non-motor symptoms, non-movement symptoms, that go along to create problems with quality of life, poor function. Seeing the stooped person with a shaking arm, slow shuffling gait, that's only the tip of the iceberg. What we see on the right side of the screen, the Lewy body and the changes that go along with Lewy bodies also address non-motor symptoms. So sleep issues, low blood pressure, constipation, bladder control, a number of things that are still unmet needs when we talk about treatment. Dopamine is essential for normal movement. You'll see on the right side of the screen, on the left side of the screen, two slides, two pictures, one on the left with normal dopamine uptake and on the right with low dopamine uptake. And the picture here is just to illustrate that when the cells that produce dopamine are not delivering enough, that's the chemical change. That's the chemical change that results in the symptoms. We can see this visibly on different kinds of brain scans, and of course on looking in the brain tissue itself. After a person dies and you look at the brain, you can see those changes. But the good news is Parkinson's can be treated. Balanced treatment for Parkinson's involves a number of things. Exercise, rehab services like what they do here at St. Luke's and our other excellent centers around, physical therapy, occupational therapy, speech therapy, careful selection of medication, and deep brain stimulation if and when needed. A person who's in their late 80s and diagnosed with Parkinson's disease likely can be treated for quite a long time and have pass out of the window where they really even need DBS. Whereas someone with Parkinson's diagnosed in their 30s, which I have a number of these patients in my clinic, they're certainly going to need something else beyond the typical medication treatment that we do. And now we have to add even more to the slide than just this, and we'll do that before the end. Currently, we work with medication to replace dopamine, make dopamine last longer, that's produced in the brain, but not in high enough amount or not for a long enough period of time, trying to recreate through the use of different kinds of medication a more natural amount of dopamine in the brain. It's not perfect. Medication doesn't slow progression of Parkinson's disease. No medication has been definitively shown to do that. We've had a couple of near misses where we thought, maybe, but nothing that the FDA and frankly the Parkinson's community that really does this professionally has really been able to embrace and say that, yeah, we can stand by this. This data clearly shows that. But one thing that is kind of clear is certainly treating Parkinson's, being actively treated when you need it, when you're starting to begin to experience physical decline, is certainly better than waiting and not treating and delaying that. There's really almost no benefit and most certainly harm should a person go too long without treatment and have physical deconditioning, kind of think of themselves more as a sick individual, have changed their life so much, and to try to get that back is not really possible if they've gone too long without some kind of treatment to sort of, if you will, arrest the symptoms, though we're not changing the issues with the brain. But current medications and surgery fall short of addressing quality of life issues for many people with moderate to advanced Parkinson's. Current anti-Parkinson's therapy involves use of levodopa, Azilect, selegiline, dopamine agonists, the Nupro patch. So these medicines either replace dopamine or stimulate dopamine receptors in a way that's very similar to levodopa, though not identical. Amantadine is a medicine that's unique among anti-Parkinson's medicine, that it helps Parkinson's symptoms but suppresses dyskinesia. Artane, medicine that works only to reduce tremor, not the slow movement and stiffness. Apokyn, which is an injectable Parkinson's medication. Entacapone or tolcapone, and deep brain stimulation. All these have unique advantages and unique drawbacks, and managing medicines is what I'm here to do. That's my part in this. That's how the movement disorders neurologist has a role, and goes early on throughout advanced Parkinson's till the final days. Medication for Parkinson's helps. It helps quality of life. It may not dramatically make someone able to walk again or go from that state of being frozen to being able to walk amazingly well. But even with very advanced Parkinson's, medication is tremendously helpful for quality of life and comfort and that sort of thing. So medicines will always have a role as far as I can see. Now a bit about levodopa. We're going on the 50th anniversary of levodopa. I got my movement disorders journal last month, and it said 50 years with levodopa. So they were picking apparently, sometime right in the middle when I have up here as when levodopa actually came onto the market. But Berkmeyer and Horwitz injected levodopa into Parkinson's patient years ago and noticed dramatic improvement. That patient became horribly ill and vomited and very sick to their stomach, and that's when we realized that levodopa not only did it help Parkinson's, but it had some side effects. And this is going to continue to be a problem with levodopa, that it's a great medication, replaces dopamine, turns the switch on, the on effect, the main anti-Parkinson's effect, that allows so many people to look essentially normal rather than the Parkinson's state. But it has side effects. And the first side effect that levodopa, that we encountered with levodopa was nausea. And so it was by introducing carbidopa with levodopa, using the term syn-met. I have a degree in Latin and Greek, a little bit of biochemistry. So I guess that's the one thing I take away from my college education is understanding that syn and met without nausea. So that is kind of how Cinemet and carbidopa-levodopa combination came about, and ever since then, the rest is history. We've been able to use this wonderful medicine, but it has lots of limitations. It's still to date the most potent and tolerable medication available, but there are problems. Levodopa chemically is quite similar to protein. It's an amino acid, chemically, large neutral amino acid. It's identical to a number of different types of amino acids that we ingest through our usual diet, and meat and non-meat products as well, meat and non-meat food. Levodopa first has to get past the stomach into the small bowel. When it gets into the small bowel, that's the site of absorption for this medicine. And the onset is quick. It goes into the blood quickly once it gets to the small bowel, and into the brain quickly within minutes. But in practicality, that happens about 20 to 30 minutes for most people when they have low enough dopamine that they're truly more in need of this and more dependent on it, if you will. Not only does it have to enter into the bowel, but it also has to enter into the brain. So anytime a person has a meal with protein in it, with the levodopa present at the same time, it may not be absorbed into the blood through the bowel, and then into the brain, from the blood into the brain. Two sites of potential blockage. Chemically, it's a little tricky, and that's why we ask you to please try and take your medicine half an hour before meals for levodopa only, carbidopa-levodopa only. That's really where that comes from. Most of the time, as long as the stomach's moving well, that's not an issue. However, kind of like with diabetes, where there's slow movement of the stomach, in Parkinson's disease, there can be slow movement of the stomach. And that can account for what we call dose failures or delayed on effects. So taking the medicine, drinking, waiting around, not eating for an hour, still shaking, not waiting. The medicine may not work. Why is that? Well, it's because it can sit in the stomach. Even on an empty stomach, the gastroparesis, the movement of the stomach, is slow. So that's a problem. Talk about that today. Ultimately, the other issues are Parkinson's progression ultimately results in symptoms that poorly respond to levodopa. Balance, cognitive impairment, and these non-movement symptoms. Levodopa can treat some of the non-movement symptoms, not directly as we understand it, but clearly all Parkinson's docs have seen meaningful improvement in non-movement symptoms unintentional. We take credit for it when it happens, and oh yes, well that's going to happen. That's supposed to have happened to you. But no, in all honesty, like mental clarity, balance, things with balance that we really wouldn't expect to improve with levodopa. I've had a guy tell me the other day he could go to the bathroom better. I'm like, well, great. I don't know why that happened, but I'm very glad it did. It was a clear benefit, not one of the typical things. So what happens over time is going from a state of normal, fast movement, relaxed muscle, lessened or no tremor up top. This is the on state. And I encourage you to use these symptoms or use these terms as much as possible. Try to learn them, because most Parkinson's docs you'll see, wherever, are going to understand kind of the on and off. And particularly when we're talking about the medicine effect on and off, it sort of just sums it up. And you start to associate more what is a medicine effect versus something that's independent of medication. And that's very important, as your doctor may need to adjust medicine. So the on state versus the off state. The off state's the Parkinson state. Slow movement, stiffness, tremor. That's what we're treating. We're treating the off state to get more of the on state. Inevitably, because of the progression of the condition, because of the progression of Parkinson's disease, less dopamine is present and available for the brain to use. It becomes more sensitive to levodopa and dopamine replacement. The way that we replace dopamine is giving it by pill form. There's short acting, there's long acting. There's plus and minuses to both, but what ultimately happens is the brain's seeing a burst of activity, up and down, up and down, up and down kind of activity over time. And with this up and down activity, over time, the brain is getting sensitive to this pulse of dopamine, and that triggers dyskinesia, involuntary movement, and the on and off effect, this kind of quick switch on and off. Early in Parkinson's, this doesn't happen. Some people will question diagnosis, saying, I don't really feel it's wearing off like I've read about, but my tremor's better, I can walk better. And that's great, and we hope that lasts as long as it can. But inevitably, the medicine does kick in and wear off. Now, we use other things like the dopamine agonist, the patch, the Requip, Mirapex, Azilect, to try to use less levodopa, not give as much levodopa to trigger less of the on and off effect and trigger less of the dyskinesia. That's the whole point of using multiple different kinds of medicines. We don't want to dope our patients up, but give them medicines, give them multiple medicines, hopefully at a lower dose that won't dope them up, won't make them feel sedated or have lots of side effects, and in fact, the opposite, make them feel better, rather than relying on only one thing like levodopa at a high dose. But side effects like dyskinesia, due to the pulse, the burst effect of levodopa replacement, occur over time, and they occur more with people with advanced disease, moderate or advanced disease, in terms of their motor system than people with mild symptoms. Now, they may be able to walk fine and function amazingly well when their meds are working, but it's that fluctuation that really defines going from mild to moderate Parkinson's disease at that point. We call that motor fluctuation, wearing off. So you start off with a lot of on time and a little off time. If you can see this curve here, you see that if this is a day in your life with Parkinson's disease, maybe 3 years, I don't know, maybe 2 to 3 years into it, if you've really kind of tied in the medicine effect, you see you spend most of your time in the on state. Most of your time is in the red here. Little times in the green, little times in the off state. And that's not perfect, but that's better than being only in the off state with predominant Parkinson's symptoms. But over time, many years into the condition, you see the on state, the time available that you're in the on state is less, and the off state more. And time in the off state is the unhappy time. That's the time that you rely on other people to do things for you. You feel less confident. You're not going outside. Getting dressed takes twice as long or longer. More tremor. And then when you're in the on state, finally, you feel better. You take the medicine, it kicks in, and you're on, but with dyskinesia, the involuntary movement. There's a very small window, some would argue it doesn't exist, that a person can be on without dyskinesia. I personally, my feeling and what I've observed clinically is it's pretty rare that a person's on without dyskinesia of some type, several years into Parkinson's, on an appropriate levodopa dose. In fact, the way that I can usually tell my patients not taking enough medicine in general is that they've got Parkinson's symptoms, they're complaining about that, and I see no dyskinesia. I've heard of no dyskinesia at all. There are some good reasons for that if they can't tolerate it. Sometimes it's a fear of the medication, but most people that take levodopa will be able to take it for a number of years with only mild dyskinesia. It's quite rare that a person has dyskinesia, let's say, as bad as Michael J. Fox. One of the reasons he has dyskinesia like he has to the degree you've seen is because he's a young onset person. People with Parkinson's that are younger onset tend to have a harder time with dyskinesia. I suppose it's one of the good things about getting older, if you happen to have Parkinson's, that dyskinesia is often not quite as severe. So, feather in your cap, I suppose. But it's one of those things that we still have to deal with because it's still a quality of life issue. On time with dyskinesia versus off time, trying to balance them. Now, how do we do this? Levodopa, talked a lot about this. Immediate release, quick onset, quick wearing off. Predictable, but dosed frequently as Parkinson's progresses. My form of levodopa I most strongly prefer up till now has been immediate release levodopa. With quick on and quick off, I can tell my patient exactly when to expect to take it. I can work around that. I can control it. I like controlling things. It makes me feel in charge, and it makes my patients feel in charge. Well, you're never really in charge with Parkinson's disease, but you certainly can try to stay on top of it. And having the immediate release levodopa is predictable, and that predictability is the one thing that we can try to get control of, and a lot of times people really like that. Controlled release is slower onset and has more irregular wearing off. It's often a good medicine to use early on in Parkinson's or when dosed at night in more advanced Parkinson's. What happens when you take this controlled release at the levels in the blood, if you take a kind of a large dose, it can actually go up and down quite a lot and create a lot of variation in the on and off state. Kind of Parkinson's 1 minute to dyskinesia the next, and vice versa, back and forth, and be really hard to control. Controlled release levodopa in its current form also has a very big problem with interaction with food, because it takes a long time to get absorbed like it's supposed to, but also it's around longer with food to interact with. So it's more prone for food interaction, which is a problem. So this is kind of what things look like with the immediate release. This isn't an ideal situation. I made all these curves up, okay? But this is kind of the ideal thing that happens with most patients. And those of you that take immediate release levodopa will probably recognize that this is sort of what's happening for you when you fluctuate it. And this is what's happened with the controlled release stuff, the dashed line, if you're able to see that well. You may take a dose and it may get you on with not much dyskinesia initially. It feels better. It certainly doesn't cause things like that big nausea. If you remember, if you've ever encountered the levodopa-associated nausea, it can be quite bad. CR doesn't always really trigger that quite as much. So that's one of my tricks, one of my strategies for those that get nausea with the levodopa. Give them the CR. So that first dose might work fine, but the second dose, you may take it and it doesn't do anything. There's kind of a delayed on. In fact, the person stays off, and then they take another one, and that builds up, and it shoots you right up into dyskinesia. It can kind of build those levels up very, very high and kind of stay that way for a while. And that's the drawback of relying only on CR. I'm not going to spend a lot of time on the medication here, these other medications, but Azlec, the Nupro patch, and Tacopone, they're all the intention of these medicines are to be used with the levodopa to make it last longer, so that we don't have to give as high enough amount that drives the dyskinesia, that pushes that up too high. They all have side effects and cost, of course. Cost is an issue when you start to take multiple different Parkinson's medicines. So how about something new? All right, so that's the background. Any questions so far from the room here in Spokane before any burning questions? We'll have time at the end. Maybe take one if there's one, or I'm happy to keep moving. Okay. So Rytary, this is a new oral extended release carbidopa-levodopa pill. So another pill, yippee! But this is I'm really excited about this medication. Like the other medicines that have been approved to treat Parkinson's, it's looked good in its clinical trial information, and I think it's, from what I've talked to investigators that have worked with this so far, there really is some good difference with this. This is kind of a hybrid. It's carbidopa-levodopa, immediate release and regular release put together in one pill. You might say, well, why didn't they do that before? Well, that's a good question. There's drawbacks to both. And the real breakthrough here is there's this special kind of bead matrix system, this backbone, this chemical backbone within the pill, where it's actually having immediate and short-acting release together at the same time, but at different rates. And so that's allowing it to have both a quicker acting and longer lasting effect. In the studies that have been done, it may allow up to 6 hours between doses for people with moderate Parkinson's. And a 10% higher levodopa blood level with Rytary has been shown than with the standard preparation of either carbidopa or levodopa, short or long acting. So the large pivotal main clinical trial that was done looked at over 400 people that were randomized to get either Rytary or immediate release levodopa, carbidopa, levodopa for 13 weeks. Doctors and patients didn't know what they were getting. They found that off time reduced by 1.17 hours compared to immediate release levodopa. It's pretty rare that you take a single medication and get less off time than immediate release levodopa dosed with best management. We've taken a lot of things like Azlec and Tacopone, other new Pro patch, we've added those to levodopa and shown more on time. But just to take one pill and have more on time than the regular levodopa really hasn't been shown. When controlled release was compared with it, it really didn't. It was just more convenient. So what they found is that people that were taking the Cinemet 5 times a day were able to convert to this Rytary and take it 3.6 times a day, round up, round down if you're an optimist or pessimist. So they were at least allowed to get one dose, if not perhaps 2 doses less per day on this new preparation, which is a couple things. I mean, it's convenience-wise, it's better. It's less likely to build up in the system, a little more predictability. So that's a pretty hard sign to me that it's something that I want to have as an option. How about dyskinesia? We've seen what happens if it builds up or it gets maybe a little higher than a person is tolerant of. Well, there was more on time without troublesome dyskinesia with Rytary than with immediate release levodopa. There was no increase in on time with troublesome dyskinesia. That means the bad dyskinesia, the really big, wiggly, exhausting dyskinesia. Okay, so on time with maybe a little mild excessive movement, there was more of that. What was the overall general impression? Both doctors and patients independently said whatever that group's getting, the patient said, I'm happy, I like this more, and then the doctors also said the same thing. Quality of life ratings were also favored for this Rytary group that took this new formulation, but it was all driven by improvements in mobility. So there are mobility-related quality of life issues, and there's kind of other stuff, these non-movement symptoms. Didn't really help that, which makes sense because we know that levodopa usually doesn't help non-movement Parkinson's symptoms. So everything about this study sort of made sense, and I think the take-home point is that we have a new medication on the market as of 2 weeks ago, finally. I've been waiting for this to get released for like 3 years. A new medication on the market that is another option. It has going to have a role. I think the more we use it, the more we'll know about it. But probably a role for people perhaps early on, certainly I would say moderate to advanced Parkinson's where the meds are kicking in and wearing off a lot, and we want to smooth that response out. So the future, well, the future is now. So if you've heard about the Parkinson's pump, this is Duopa. This is what it looks like. This is about the size. It's kind of a fanny pack / man purse size combo, more like a fanny pack, I guess. This is basically, from what I've seen, this is more or less what the device looks like too. It sort of kind of has that kind of interface. So we've talked about levodopa wearing off already. Talked about everyone kind of understands that as the blood levels go up and down, ultimately what happens to your body goes up and down and is tightly connected to what the blood levels of the levodopa are at, where they're at. Over time, shorter duration of benefit and dyskinesia. But it doesn't lose this effect, but there is certainly a shorter duration of benefit, dose to dose. So regardless of when levodopa started, wearing off occurs, and it's more related to the relative dose of levodopa. The more levodopa you take, the more dyskinesia you see and more wearing off you have. Well, a person may say, well, why not just reduce the dose? Well, we could, but then you'd be Parkinsonian most of the time. which is shown to be even less satisfying than having some dyskinesia. Parkinson's meds, again, work together to lessen wearing off, and this is our chart to remind you about how the levels go up and down. This is the blood levels of levodopa and how that kind of interacts with the different state the body's in for each point in the dose cycle. So with this idea of Duopa, carbidopa levodopa infusion gel, continuous levodopa supplementation to smooth out that response. It's used for 16 hours a day, a cartridge, 16 hours a day. They give you a period, an 8-hour period in between there off meds to sleep where you don't have to have this pump hooked up. You take your evening carbidopa and levodopa dose. It goes through a tube from the pump, which is worn over the shoulder or wherever outside of the body, tube going into the small bowel, into the stomach, through the stomach, down into the small bowel. So there is a tube put into the stomach. Very clear about that. If you've seen the diabetic pump, this is very different. This is a different thing. This is the tube, hole in the stomach, tube through the stomach, and then it goes further down, okay? So the diabetic pump, which people I've talked to a number of times, I think they're convinced that it's going to be identical. It's very different. That's a smaller, very small cartridge, looks like a doctor's beeper, with the tube into the fat, just right under the skin. So it's different. It's an invasive treatment. The idea here is to put the tube not in the stomach, but past the stomach. Why is that? Does anyone remember why would we get the tube? Why would we want to deliver the medicine past the stomach? Right. You get past the stomach not moving fast enough, and the medicine is delivered and absorbed quickly right at the point where it's capable of chemically entering. And that helps with the delayed on, the dose failures, the predictability aspect that's really bad about having to take Parkinson's medicine. And this is a picture. This is the best picture I could find. It looks like my kid drew this with a crayon, but I couldn't really find it. The company, in their defense, they don't have, their FDA is not allowing them to release any commercial illustrations, whatnot, until April or May. So anyways, but you get the picture here. The pump's on the right side of the screen here, the blue device. It hooks into a cassette with a tube connector that goes into the tube that goes into the stomach, which then goes through the stomach, inside the stomach, into the small bowel. It's taken a number of years. This has been available in Europe and Israel for the last decade. Because of this tube being very tricky to manage, there have been some delays for this coming to the U.S. market. That's mainly why. That's one of the bigger reasons. Also getting the company to bankroll it and all that sort of stuff that goes with the business. But that's been one of the things they've finally, we think, worked out. So what does this do? What evidence can I stand on and say that you should think about this? Well, there is a 12-week double-blind placebo-controlled trial at many different centers. I think it was like 10 different centers. 71 patients started the study, 66 finished. So pretty good. There were some dropouts, but that happens for all studies. It's not horrible, dropout numbers. Both received some levodopa. Well, actually, I take that back. This is actually incorrect. One received all their levodopa in a pill form. The other received their levodopa all in the infusional form, the form of the carbidopa levodopa infusion. The trial was designed in such a way that neither could tell if the active treatment was coming from the pill or the pump. So they both got a pill and a pump. Just one group got the real deal pill, and the other group got the real deal pump. And this is what we do in science. We don't take anything at just what he said, she said. We test it. And so the doctors nor the patients actually knew who was getting what. So it took them about 7 days to titrate it. So they didn't pop it in, put the pump in, and you could just, dance. They had to titrate it a bit. And so this is for the study. This was actually done in the hospital. They did initially, for the studies before this, they did a tube feed through the nose for a few days, and then the device insertion, which fortunately we don't have to do that for the treatment now. But about 7 days after starting, the stable dose was found. And yes, they used the outpatient dose of anti-Parkinson's medicine, the levodopa. They converted that to an equivalent dose to know how much to use. It wasn't just like a random, let's try this. What they found was measuring blood levels of levodopa. There was significant stabilization of blood levels of levodopa in the group with the real gel compared to the placebo gel. There was about a 50% reduction in off time. on time without bad dyskinesia, so on time but you're having just minor dyskinesia, improved by nearly 50%, and on time without dyskinesia over 50% compared to the people getting the real levodopa pills. So they were taking their real, like as many of you are right now, their real medicines, but their on time reduced even that much more, or improved even that much more. Also, they noted improvement in quality of life and ability to do daily activities in the pump group. Now, there's going to be some more detailed information coming out in April about this. They've embargoed the study information until the poster presentation. But also, it seems there's very likely some quality of life improvement independent of motor activities, which is really interesting, really neat, because you don't see that a lot with levodopa trials. Probably that's related to having minimal fluctuation in the blood level. Okay, so you've heard a little bit of this initial kind of talk about what does a day with levodopa, a day with Duopa look like? Well, the pump is hooked up to the tube. In the morning, you hit a button for a morning bolus, a morning dose. Hit it, boop, and you get your morning bolus. And it's about 100 to 200 milligrams of levodopa, based on kind of how I've calculated it. They dose it in milliliters, but there's you know how much is in the milliliter. So it's going to be about 100 to 200. So it's not that different than a moderate to advanced Parkinson's patient might take in the morning, but you don't have to take a pill. It goes right in. Don't have to worry about the stomach not absorbing it. And then you hit a start infusion button, and then that's when your continuous levodopa infusion starts. And that's what I would determine. We would work to figure that out, and you can adjust it. You can adjust the rate. Right now, I believe in the pump, you'd have to come back to the office to adjust the rate there in that pump. And then you have the ability, this is really cool. This is a new feature from what they had in Europe, I believe, to have an extra dose. So you have up to 5 times a day. You can hit the extra dose button and get an extra dose rather than taking the pill form. Well, you may say, well, why not just take the pill form? Just a pill. Well, again, there's the predictability aspect, getting it past the stomach. And this kind of is more copacetic and given, as your levodopa supply is given already with the infusion. So I think you would want to probably use this. Safety. So they went on in that 12-week trial. They converted it to open label. Okay, so they ended up giving everyone at that point, the people that got the levodopa gel knew they were getting it, and kind of like, yeah, I knew it. I could tell that was really me. And everyone says that. And then the surprise people. I thought I was getting it, but no, they weren't. And so they had to eat their shoe there, but no, they all got levodopa infusion gel. And then that was continued on for another year to say, okay, well, we've already given these people these, tubes and pumps, and let's let them, have at it for a year and live with this and tell us what we need, what else we need to know in living about this. So this was tested with a controlled trial and then on in an open label trial for another year. Again, 3 centers, 13, 3 centers in the U.S., 13 worldwide. And then they also enrolled other people at this point. They enrolled others in the study and had 54 weeks of this continued infusion. And 77% completed the study. So that's pretty good. I mean, you think about it, if you're taking a treatment, how often do you start an anti-Parkinson's treatment, any of you who've had Parkinson's, and never discontinued a Parkinson's medicine that you've started? Raise your hand if you've never discontinued a Parkinson's medicine. So there are a few. So, but for these people, 77% of them completed this study, and they continue this treatment all throughout the year. So tolerability-wise, I think that says a good thing about it. They're having a tube put into the stomach and this medication infused. That's a little bit beyond what we would normally do for a drug trial, right? So 3/4 of them here finished. Now, most of the complications that were found were deemed to be, by the Safety Monitoring Board, mild to moderate and short term. 35% of complications related to stomach tube insertion occurred, and this is by far the biggest problem. If you're like, what's the most likely thing to go wrong with, like, DBS? What's the most likely thing to go wrong? We say, well, in the trial, maybe it was 10% people got infection. Okay, and that's still true to this day. The most likely bad thing with DBS is infection. Well, here, the most likely bad thing to happen to you is to have complications related to the stomach tube insertion. That's actually a pretty high number. 35% is fairly high for a procedure, but the vast majority of these were short-lived and within the first 2 weeks. So if you have this and you get through the first 2 weeks and it's appropriately managed, odds are you're going to do pretty well. Most people dropped out, did so right away. Significant benefits were noted within 4 weeks. This is, getting your doctor to troubleshoot it, figuring out what to do with the other pills, maybe drawing those back down, getting off the patch, getting off some other medicine, and then you get worse, and you have to push up the levodopa pump again, increase the dose. So trying to find that sweet spot. Took about 4 weeks. At that point, there's a 4.5 hour reduction in off time versus their baseline. So for many of these, they weren't always optimally managed. Movement ability, daily tasks, and quality of life were shown to be better in the Duopa group. And this is a chart here. It's kind of complex. Don't worry about looking at all these in details. Let me walk you through it. Look at the chart in the upper right-hand corner of the screen for our people that are in other sites. If you see the upper right-hand corner, weeks 1 through 4. If you look down there, you'll see weeks 1, 2, 3, and 4, and the percentage of subjects that had complications from the device insertion, nausea, pain, hurt to get a stomach tube put in a little bit. For 25% of them, it dropped dramatically at the 2-week mark. So not necessarily a long-term issue there. So that's pretty favorable. I'm excited to start using this treatment. We've got 2 patients signed up for it already. We're getting in the process of getting it going and working with. Currently, we talked to Inland Imaging to be our go-to people to put these tubes in. Don't envision that it will require a hospital stay. Perhaps if so, a very short one overnight, a hospital stay, that sort of thing. And there's lots of support available from the company for this. So who do I think will have this done? I think this is probably going to be the best fit for those that have contraindications to DBS surgery. I think for people with moderate advanced Parkinson's disease that have moderate cognitive impairment or have some dementia and they're not candidates for surgery, I think they're going to be great candidates for this. For people who can't walk, but their minds are good, but they have some issues with Parkinson's or some other things making it so they can't walk. Usually we don't do DBS surgery on those people. This is going to be a great treatment. So for me, this opens up options for people that right now we had to see and say, well, I'm sorry, you're kind of out of the window for DBS. Let's just do our usual thing. Now we have this, and it's not perfect. It's a tube through the stomach, but it's going to be great if you have really bad dyskinesia or you've had problems with levodopa intolerance, hallucinations, low blood pressure. There's all sorts of things that can happen that are individual. This is going to be a great treatment. I'm going to really encourage my patients that are willing to get this, those with multiple medical problems, their health is maybe too frail to have DBS, but I think they're going to benefit from this. If a person's really, who do I think wouldn't be a good candidate for this? Well, it's all individual, and some people come to things with a strong preference not to have a wire put into their brain and a hole drilled in their head. So that's nothing to be taken lightly, and some people cannot get past that. And for those people who otherwise we would be kind of under-treating and not really able to get them with good therapy, this will be nice. But I don't think that if someone's pretty active, for your more active patients, I really don't think, this isn't what I would recommend. Based on my current understanding of it right now, maybe it will change the longer I use it, but I just don't see my more active patients that, walking around that are doing great with DBS, walking around with a tube into their stomach and a fanny pack. I just don't think that's going to be as good of a fit. But a lot of it will come down to personal preference. So it's just nice to have other options. So calcium channel blockers in Parkinson's disease. Just a few short slides. I'm going to cut it short here in just a few minutes. But many of you have heard about isradipine for Parkinson's disease. This is a calcium channel blocker. There are a number of clinical trials opened around the country in the last month or so. They just started Steady PD, which is a phase 3 trial shown in animal models to possibly slow the progression of Parkinson's symptoms. We know that dopamine-producing cells are sensitive to calcium. Overflow of calcium into dopamine cells may harm it, and therefore its ability to produce dopamine. Phase 1, which was a safety trial. Phase 2, which was a dose-finding trial. We think we know that this is a safe treatment, and we know that approximately the best tolerated dose for isradipine. This is already a medicine used to treat high blood pressure, so it's kind of a repurposing of an old medicine. This has been this new thing with the government's released a lot of funding dollars to try and repurpose old drugs rather than giving bazillions of dollars trying to reinvent new things. Let's make sure the things we don't already have out in practice that are safe can't be used to treat other conditions. So this is kind of part of that thing from the government. But will this actually work in humans? We know that it's been shown to have favorable responses and improvement clinically in animals and monkey models of Parkinson's, but will it work in humans? Most of the things that have worked in animals have not worked in humans, unfortunately. So I don't necessarily have high hopes, but I'm cautiously optimistic. So the goal is to look over 3 years, which is an exceptionally long time, 3 years of isradipine versus placebo in untreated Parkinson's patients. So de novo. So I'm sending my de novo, my newly diagnosed, untreated patients that are interested. I'm sending them to some of the regional sites. We don't have anything going with this trial. I'm petitioning to try to get on as a site, but I don't know if we will or not. To take part in this, though. And the goal is, over this long period of time, will the group that's taking isradipine, how will they fare compared to the placebo? Will it be tolerated well? Will there be unique side effects to Parkinson's patients that we may see with this old medication for this new indication? Will it affect only movement or non-movement symptoms of Parkinson's also? All right. Well, there's coffee in the back. I have some other things about caffeine and stuff like that, but we've got 30 minutes, Cindy. Is that right? Well, 30.
Yeah, approximately, yes.
Yeah, so let's go ahead and take some questions now.
If you have questions, we have a mic here. Okay.
You want to call on people?
I probably don't need a mic. You mentioned the calcium connection, which was new to me. I didn't know that. Is there foods and things that we should be avoiding if we're taking medication for Parkinson's, such as ice cream, milk, whatever? Should there be a limit on how much calcium was actually taken in with our regular diet?
I'm not going to say limit your ice cream because I'll be booed out of the room. I'm not in Wisconsin anymore, so I suppose I can say limit milk. But no, in all seriousness, I wouldn't. We don't know enough about this stuff. What's happening is this isradipine is a calcium channel blocker that's blocking calcium that's being taken up into specific cells in the brain. That's a highly regulated, highly protected area. So in all likelihood, you could double dose calcium pills in terms of your vitamins, that sort of thing, for bone health. And in all likelihood, you're not going to make any change because it's so tightly regulated. So really what they're looking at is trying to see, well, can we just decrease the normal amount of... They're not looking at saying that calcium's too high in Parkinson's patient. Therefore, we should do something to block it. They're looking at, well, let's just say that their calcium levels are normal, but for some reason they're more sensitive with Parkinson's. So let's try to lessen that response even further, to try to lessen that sensitivity of those cells to calcium even further. I doubt anything you're going to do in your diet, as far as I know. I think it's going to be a very, very low risk thing to eat calcium-containing foods. And in fact, I would go so far as to say, with the information we have right now, you'd be doing more harm than good if you limited your calcium. I mean, osteoporosis. We don't know how this is going to pan out, but we know that low calcium intake and bone loss in older people is strongly associated with falls, with injuries. So I would not do anything like that.
Okay, great. Thank you.
Yep.
I'll try to make the question softer than I think it should be. But in your slides, you showed levodopa was injected in 1960.
61.
Okay, and clinical trials started?
69.
Was the FDA around then?
I wasn't around then.
No, but
I don't know.
The real question for me is that, so they tried it first and then they did the clinical trials.
Yes.
You didn't, in your talk, you didn't mention anything about stem cells.
No. What would you like to know?
Are stem cells in the same situation that they're trying them now and then they're going to do the clinical trials?
Well, stem cell study for Parkinson's disease has been enrolled and completed, and they're watching to see how the patients do in Duke by Dr. Mark Stacy. And actually, I just talked to a nice lady from the Scripps Institute in La Jolla a few weeks ago, talking about the trial that they're doing. They have eight subjects where they're taking their skin cells, they bank their skin cells, and they've reprogrammed them. Okay, they're producing dopamine and waiting for a new home, but the FDA has not yet cleared it. Okay, so those are the two trials I can tell you. Now there are other groups for a very high price will inject proposed stem cells into one's spinal fluid, blood and other parts of your body at your request, it sounds like, that claim that their stem cell treatments miraculously help their Parkinson's patients. I'm skeptical. This one group it was based out of Texas, and Texas kicked them out. And you have to be pretty racy to get kicked out of Texas. So that's one thing. Secondly, they would not allow their protocols to be analyzed by the FDA, and they wouldn't actually open their books to show. And that's the cornerstone of the scientific method, and reproducibility, and so that's that. So yes,
that is a cornerstone, but levodopa might still not be out, according to your
true.
That's true, right?
Right.
I mean, I've been checking stem cells because I didn't see anything in your chart that was going to do much for me, which is supposed to be sort of in the early to medium stages of Parkinson's.
Except exercise.
I do exercise.
Good.
But what do you have on your list there besides stem cells, and why aren't you looking at them harder?
Well, we have some other treatments. Caffeine. Caffeine has been shown to.
On your list.
It is. It's just to,
there it is, right there.
Just to prove it to you, there's coffee. Caffeine was tested in a 6-week study in 61 patients with Parkinson's who were sleepy. 200 milligrams, which is about a cup, 400 versus placebo. There was no significant improvement in sleepiness, but a suggestion of a very small significant improvement in Parkinson's symptoms. So this is very interesting. It was actually tested for we thought it wouldn't really help Parkinson's symptoms, but they looked at it for the movement symptoms as well as sleepiness, and they found that the sleepiness didn't get better, but the movement did a little bit. So very interesting. We know that cigarette smoking, caffeine consumption before diagnosis of Parkinson's, a person that does more of that generally has a lower risk of developing Parkinson's. Now, don't go out and smoke cigarettes and drink tons of coffee. Certainly, coffee is not going to make the symptoms any worse. I think, if anything, we can take this home from this study. The people with Parkinson's didn't actually get worse, though you sometimes worry about that with tremor. So interesting. Next question.
Well, while they're thinking there, I have a couple questions for you.
Yeah.
What would you think about starting someone on Rytary and seeing how that worked, and if that didn't do any good, then going to something like Duopa?
I think that's where things are headed. I mean, it's my hope that, I hope that in the future, Parkinson's neurology looks a lot more like other treatments where we don't even use any of the medication that was initially available because we have treatments that are so much better. I think that the real irony here is that the first treatment that was discovered to treat Parkinson's disease is still the best treatment, and despite all the other medications that have come along, it's always been compared to the gold standard, which is the first treatment, and they've never bested it. So I think that with Rytary, even though it's kind of a repurposing of an old drug and a different kind of delivery method, I think it's been all along. It's been the delivery of levodopa that's been the biggest problem. Look at Rytary, oral pill. Look at the pump. It's all about the delivery. That's the biggest trouble with levodopa. So no, absolutely. I think starting out. I hope to start a newly diagnosed patient when they need it on Rytary, see how they do, and if they develop motor fluctuations on that, go right to the pump and bypass the old methods of having to use that if that's what they want. Or the other thing would be DBS. Go through Rytary to DBS. Or how about both? Go through Rytary based on patient preference and where they fit. Go to DBS and then the pump, or maybe the pump and then DBS. Or by that time, stem cells will be available. Finally. Which you can help, by the way, by writing your Congress people. That would be the good place to put the enthusiasm.
How we vote these things too.
And
Amen.
Do you know anything about how one converts from their current dose of levodopa, carbidopa to Rytary? Is it a milligram for milligram conversion?
Well, I haven't seen anything on that at this point. I would probably underdose by about 20. If what the trial shows is truly reflects what will really happen, I would probably underdose them by 10%. What did it say? It was, I think, at 10% higher plasma level. You want to shoot for kind of an identical plasma level, but yeah. So it's going to be 10% higher levodopa blood level with Rytary. So I'd shoot for maybe 90% of the prior levodopa dose.
Okay. And the final question that I have is that initially when FDA announced approval of this, the word was that Rytary would be available sometime in February. The latest I've heard is April. Do you know anything about that?
Yeah, I think it's the same. It's the same. Both products were released in January, and well, the pump, it just there's so many more things to jump through, but I think April is very reasonable time frame.
Okay. We'll take one more question in Spokane, and then we'll go to the remote sites.
Hi. I'm not impressed by those numbers.
I know.
Getting a big hour, who cares? Besides, the good thing about dyskinesia is that it burns off calories. That's. But I was.
Yeah, one in the pro dyskinesia camp. If you could you tell us what it is? So many people are afraid of the notion of dyskinesia. They will go underdosed for years. How would you explain to them not to be afraid of dyskinesia? I mean, not that it's good, but what would you tell them?
Because it looks weird. That's why nobody wants you to have it. Because I'm wiggling right now. Did you notice? No, I wasn't. Oh, good. See, that's a good thing. Distraction always works. But what I'm saying is, if it's not that great a change, and it's expensive, I suspect it's very expensive.
Of course. And to your point, these other medications I haven't spoken about either because I wanted to take questions. This Priatalent, these are medicines that work off this kind of a caffeine type pathway. The FDA has held, they've been shown to be pretty good too. Again, like you're saying, pretty good. But the FDA is like, okay, come on, how many of these pretty good medicines are we going to have out there? But again, I mean, one thing that the individual person doesn't see that I see, seeing hundreds or thousands of people with Parkinson's, is how unique the tolerance is, and how the subjective benefit for some people. I mean, it blows my mind. I'm like, really? It helped you that much? Really? As-Lect helped you, that, and I can measure it. So just having options out there is not a bad thing. Yes, it does. It could drive up cost of care, and those are things that I take seriously. But I think where the option is kind of waiting for stem cells versus having a couple medicines down the road, it's not going to slow down development of other therapies. So the more we can have out there, it does give options. And some people are extremely intolerant of everything but that one med, and that's the trouble here. So, question from our remote sites?
Yes. All right, so we're going to open up questions, and as usual, we're going to start alphabetically. So we'll start with Anchorage, Alaska. If you could, let us know how many people you have in your site, and then if there are any questions.
Is that the one, the monitor?
Anchorage. Oh, please unmute your line as well.
Okay, we have 4 people here, and we have no questions at this time.
Okay, thank you, Anchorage.
Thank you.
Okay, we'll move on to Billings, Montana.
We have 4 people here, and I do have a question. You mentioned that the cinnamon can build up in the system. So what happens, what are the symptoms of that buildup, and how long? So if you start having hallucinations and things like that, probably from the carbidopa, levodopa, or entacapone, if you drop the medication from 4 times a day to 3 times a day, or how do you prevent the buildup, or how do you get rid of it?
Well, fortunately and unfortunately, levodopa doesn't stick around in the blood very long. So if you stopped it, if you didn't take the next dose, those symptoms would almost certainly go away within hours. So that's a good thing. And when you're trying to get good benefits, that doesn't work. It's not a good thing. But rather than decreasing the amount of times per day you take it, the best strategy would be to either probably what I would do in that situation is to reduce the dose of the levodopa, continue the entacapone, because you don't want to do anything about how long it lasts. You want to maintain the good duration of benefit, but lessen the side effects from the levels getting too high. And that's largely dictated by the amount of levodopa that you take. So just not necessarily even cutting it in half. If you take a 250 and cut it in half, that's a pretty big reduction. But if you're taking a 25-100, cut it in half, that's different. So sometimes, like I've seen that happen, a person's taking 25-250, and doc calls, well, I'll just cut it in half. I'm like, whoa, no, let's not do that. Let's convert them to a 25-100 and take 2 of those along with the entacapone. and then continue it 4 times a day or whatever frequency you were taking. That way you're getting, what's happening is you're getting less, I'll show you, it's the dyskinesia curve. It's all in this simple diagram is really it for Parkinson's. You're getting, if you switch back to the slide for them there, you're getting, you're lowering your peak levels here. And your peak levels is not only dyskinesia, but it's the other stuff too. It's the hallucinations. It's the this top of this curve here, the top of these lines. You're just going to lower that. So it's hallucinations, low blood pressure, confusion, all of that's been shown to be a levodopa correlation for that individual person. Now what happens sometimes we'll reduce it and the hallucinations continue. Well, it could be another medicine more commonly because levodopa can cause hallucinations. It's not that bad compared to other anti-Parkinson's medicines. Or, unfortunately, people with advanced Parkinson's disease, because of the disease, can have hallucinations. But we do have to make these changes to figure it out because it's not currently, we're not able to know otherwise. Okay, good question. Next.
Clarkston, Washington. How many people do you guys have tonight? Any questions?
Hi, John. This is John Smith. We have 10 here, and we have a couple of questions.
All right. Thanks, John. Hi, John.
Hi, Dr. Aldred. How are you?
Good.
Do you know anything about droxidopa?
Yes. Droxidopa is new medication to improve low blood pressure with Parkinson's disease. So it works kind of like a sympathetic kind of fight or flight thing. Same stuff that raises your blood, similar pathway that raises blood pressure when you're scared and need to run out of somewhere real fast. They harness that chemical ability to give this medicine to raise up low blood pressure in Parkinson's. So what this goes along with are other medicines like midodrine. Midodrine you take a couple times a day to lower to raise blood pressure that's too low, causing lightheadedness. Florinef is a medicine that makes you retain salt, and by doing that your blood pressure doesn't get as low. So that's another medicine that will do that. Of course, the first thing if your blood pressure is too low is to make sure to get off of the blood pressure pills that are causing it. Half the time that's the situation. But Parkinson's disease is associated with low blood pressure and fluctuations of high to low blood pressure as it progresses. This is one of the most bothersome non-motor symptoms of Parkinson's, and droxidopa has a role for that. Personally, I've got about 4 or 5 people I've prescribed it with. I haven't been super impressed by the coverage side of things, payer-wise. It's not any fault of the company necessarily. It's just the payers don't seem to have caught on to this, as it usually takes them a few years sometimes to figure it out. But not, giving sugar pills. So that's the drawback. Any other questions there?
One more question. The Parkinson's fundraiser that's at the Riverquest Casino?
Yes.
We want to know what the dates are and how much.
September 12th is the next Parkinson's Hope Conference, and as much as you're willing to donate to help the PRC continue to grow and do this kind of work is encouraged. But I don't know. I think there's a nominal fee. I don't know if there's $20. The outgoing president says.
And what time? What time does it start?
I don't know. What time does it start? We don't have it. It's kind of plan on being there early. 9-ish.
Okay. Thank you.
All right. Next site.
Okay, we'll move out to Coeur d'Alene. How many people in attendance and any questions?
Hi, we've got 16 in attendance and a couple of questions.
Great.
I'm Mickey Reed, and I was wondering if this Duopa pump affects digestion in any way.
The Duopa pump is not. I'm sorry. Was your question? Is the Duopa pump? Can it be digested, or how long will it last?
Does it cause any problems in the digestive process?
Okay, so the question is, does the Duopa pump cause problems with the digestive process? No, it's been tolerated pretty well. And this is not any kind of new stomach tube, really. I mean, what they've done, it's a regular stomach tube that's been used for 50 years. Basically, same technology that usually we feed people food through these things. So, if people with stroke or brain injury, that are getting tube fed. It's the same thing. So the technology is not that new on the tube side of it. There's a little loop-de-loop, a little pigtail kind of loop that is supposed to keep it in place. And I think the main concern isn't so much that it interferes with digestion, is that little loop and tube going to stay in the right spot? In the past, there have been some issues with that, but so far it looks like the company's addressed it. So there is a proprietary tube that they recommend it be used, but it's actually made to be pretty interchangeable with just about anything, which is encouraging that it does have some, modalities there that can be used. Does that answer your question about digestion and if it affects digestion? It doesn't.
Yeah, yes, that answers my question.
And the other question that I had was, you mentioned a medicine to keep sodium levels up. Is that correct? Did I understand that correct?
Oh, a calcium channel blocker. Yeah, it's Rytary.
No, just a moment ago when you were talking about ancillary treatments, the Doxadopa?
Oh, yes. I'm sorry. Yes. Okay. Florinef. Florinef is a medicine that's being used by the kidney doctors and heart doctors for decades, and it acts by encouraging the kidney to retain more salt. And when you retain salt, fluid follows the salt, and so your blood pressure stays higher. It's generally pretty well tolerated, but usually not that strong treatment for low blood pressure symptoms in Parkinson's. So this is orthostatic hypotension, going from sitting or laying down to standing up and being lightheaded, so much so that you can't do anything or have problems, and then we would want to treat that with our medicines. Also, by the way, I should add compression stockings work really well for those, but I can't get my guy patients to adopt it very easily. They're not that tough after all if they don't want to.
And we've got another question as well.
My name is Joyce Seward, and I would like to know how Parkinson's affects, or how the different medicines affect the bladder.
Yes, Parkinson's disease usually affects the bladder by causing increased urinary frequency, so having to go pee more often. When you go pee often, usually you go a little bit, not a lot, so the bladder never really gets that full. When you get a small amount of urine in the bladder sort of takes off on its own with its own plan and starts contracting. And most of the time, if mobility is good, it doesn't cause incontinence, but it certainly can. So we use, actually the best thing to do first for bladder problems of Parkinson's is physical therapy, bladder exercises, Kegels. Men can do Kegels too. Male Kegels is the first line therapy. If that doesn't work, there are some medicines that can be used to make the bladder relax. It doesn't make it so it doesn't work. It's just not as hyperactive, and you can just go when you want. You get control back. And then there's a newer medicine. Those medicines I just described, they can actually worsen thinking ability. So I don't like to use them a lot. My people with Parkinson's that complain to me of a little fogginess because it can make their confusion worse, dry mouth, dry eyes. There's another medicine called Myrbetriq that works differently. I've been using a lot of it lately with pretty good results for my Parkinson's patients. Even more, usually people with a lot of bladder problems also have other problems with cognition, dementia, and so they're the least likely to tolerate the typical bladder pills well. So I've got a new one I've been using. Next question.
Thank you, Corlaine. Any questions last minute, or any more questions out of you guys?
Nope, we're good. Thank you.
Okay, great. So we'll move on to Colfax. How many people in attendance there, and any questions for Dr. Aldred?
2 people in attendance. This is Becky. I do have a question for diagnosed Parkinson's. Stomach ups, taking 3 times a day. Do you have guidance around ability to get the medication in, and also comfort and whether food impacting its effectiveness?
So there's some problems hearing it, but I think what you said was taking medicine, Levodopa a couple times a day, a lot of nausea, upset stomach, strategies for helping with that.
Yeah, times a day.
Well, when you take the Levodopa, probably 1 out of 20 people will be very sensitive to the medicine side effect of nausea. And so usually it's the dose of that Levodopa, and when they're first starting out, the majority of people with nausea is right when it's first started. The reason for that is the carbidopa, this part of the levodopa, has to get to a high enough level, and they're packaged together. So most people have to have about 75 milligrams of carbidopa daily to allow the levodopa to not get metabolized outside of the brain and to cause nausea, and so that's also the reason you don't see effects if you start it low and increase it. But you don't start carbidopa, levodopa. I don't. 1 pill 3 times a day like that, because usually the nausea will be a big problem. I build it up. Even doing that, sometimes the levodopa will overpower the carbidopa and cause more of the nausea. And so I usually have my patients, if it's not bad, stick with it. Take some crackers, non-protein food, and that's fine. It will make the stomach slow down a bit. When the stomach's given food, it slows down. So we'll make it slow down a little bit, but big deal. We're just trying to build up the effect of carbidopa, and the person's not going to be wearing off. So I'm less worried about that. And then once they're on it, the vast majority of people, if they have just a little bit of nausea, if they push through it, it'll go away. If they have a lot of nausea, even on 1 pill 3 times a day or whatever times a day for weeks and weeks or months, then by then usually I've given them extra carbidopa. But you have to give it half an hour before carbidopa, levodopa. So you got a pill, half an hour another pill, then your meal, then your life. You got a little time for life in between all that. So that's the problem, and but fortunately it's a small number of people, but it's very worth doing. It's a good strategy. And there's another medicine called domperidone. It's not domperignon. It's different, just almost as expensive. No, it's not that expensive. And our brothers and sisters up to the north will usually supply that to you for about $90 for a month, and it works really well. It also makes the stomach move nicely. GI doctors use it. Thanks. Next question.
Okay, so we'll move on to Colville. How many people in attendance up there? And then any questions?
We have 4 in attendance and no questions at this time. Thank you very much.
Thank you. In Colville, Chewelah, Colfax, and Othello, we hope to have our telemedicine programs in those sites going by April or May. Just FYI. So. That the PRC is funding, actually. So.
Okay, so we'll move way out east to Miles City, Montana.
Yes, this is Miles City. We have 10 smiley souls on board, and we would like to know, what do you think of the DBS treatment, and or is it too risky?
Well, DBS treatment, for the right person at the right time, DBS is a game changer for Parkinson's disease. So deep brain stimulation works best for people that have true Parkinson's, not one of the mimics. Sometimes the poor response to surgery, in fact, almost always, the poor response to surgery is when a person is selected for surgery that isn't a good candidate, and then has what we later come to find, well, that's probably not surprising because they maybe weren't good to begin with. So the people that don't do well with DBS usually are people that have Parkinson's mimics, that don't really have the robust Parkinson's medicine response, and therefore they don't do well with surgery. But generally, if a person has a good response to medicine, wears off over time, kicks in and wears off, their medicines they have dyskinesia, or they have lots of tremor that the medicines don't help, or maybe they have low blood pressure made worse by medicines. They do great with DBS. At our center, in the last year, we had three infections in the last year out of 70 cases, 60 cases. So something like that. Anyways, very low rates. So the key is having it done at a place that does a lot of them and has low complication rates. Because the most likely thing bad to happen to you if you have DBS is an infection, and if that happens, it's actually not horrible. It has to get removed. Usually, the surgeons think they try to treat with antibiotics and keep it in, but most of the time I've seen it has to get removed. The majority of the people that have it removed want to have it put back in as soon as possible, particularly if they've had it in a few months and gotten good benefit from the treatment. So yeah, I'm a fan of DBS. I've seen it change far too many lives and I've seen harmed by having the surgery done. But it's not without risk. The risk of stroke is low, about 1 out of 1,000. I've actually had a patient with that, not here in Spokane, but in Wisconsin. I don't think we've had any here. But the risk of really bad life-ending things with DBS are very low. Or severe disability, yeah.
Thank you very much. A great program.
Thanks, Smile City. Okay, so we'll move to Moses Lake. How many people in attendance and any questions?
Hi, we have 13 in attendance and several questions. With the extended release, carbidopa, levodopa, how do you avoid the eating protein? Does that, or do you have to?
Well, yeah, you're still going to have the same, the extended release carbidopa, the new Rytary, the new one, and then the pump, it's still going to be the same issue. I think what's unclear and what we're all kind of waiting to see is in reality when thousands of people end up having these in over the next 5 to 10 years, how much more tolerant are they of eating higher protein meals? Most people don't eat gigantic like protein meals. It's not that common that you eat that much of it. And the bigger issue is probably this eating something and the stomach slowing down than it is the protein getting in. When the protein interacts with levodopa, there's usually, if the person's that sensitive, the results are usually dramatic. There's usually a dramatic, striking change. I've seen this in a DBS patient of mine who we wanted to program one day, and he forgot and he took his meds. This is in Portland, and I was like, well, what are we going to do? We've got an hour, and he's like, oh, wait a minute, sausage biscuit. He went down and got a sausage biscuit and ate it, and he couldn't move, within 15 minutes, and we did his program. So those kinds of patients are very rare. But most of the issue with protein in food is that particularly protein more than other foods really slows the stomach down. Carbohydrate in the stomach doesn't slow it down as much as protein does because the stomach chemically has to work harder to secrete things and do different movements to digest that protein. So I'm thinking, long story short, what I'm saying is I think that having the tube past the stomach is going to be the thing that really helps the Duopa. With Rytary, I think simply having a more reliable kind of release of the medicine is also going to be better. How much? I don't know exactly yet. All these people in these studies, though, they all ate. They all had meals, and they were probably more careful than you will be in regular, life because they're in a study, and that's always what you see in studies is always the best situation, So I don't know. I think it's going to get better than it has been for food tolerability and protein for those reasons I've described, but I think there's still going to be some issues.
Okay, thank you. Is Radipine, can someone be on that trial if they're not on levodopa carbidopa?
Yeah, if they've
just
never
on
been,
those other?
No, completely untreated.
Ever.
Okay. That's why they have a lot of centers because each center is probably only going to enroll like maybe 10 subjects. So.
And what is your this new program where you can have a doctor's visit with telecommunication?
Yes.
Right?
So our telemedicine program, I've been doing telemedicine for 5 years in Wisconsin. I have license in Wisconsin, Iowa, Minnesota. And I'm doing the clinical trial right now for in-home telemedicine in Parkinson's, looking at routine clinical care versus Parkinson's specialist on telemedicine. So we've been working with PRC was kind enough to give us a grant to support underwriting the technology cost for this. And through Sacred Heart and INHS have been very great about setting up sites at Othello and then the Chewelah, Colfax, and Colville as well. And that's going to start soon. What will happen is not as a new patient, but as a follow-up, you'll come to see myself as a new patient. And then as a follow-up, we will schedule you as a telemedicine visit. You'll go to one of the clinics, Othello, for you folks in Moses Lake. And then you'll get your care there through a telemedicine machine, very basic webcam. We talk just like this. For those that have had apprehensions about it, I'll tell you, the people that when I ask them afterwards, would you want to have another telemedicine visit or come back to see me in clinic? No one wants to come back and see me. They all want to go right by their home and get their visits. So I don't take it personally. but only in the summer months when I know they could come in. So that's sort of how that's going to work. But definitely look for that because we want it to be really busy and to entice the PRC to continue to fund that down the road. But that wouldn't happen without the money that people give the PRC to help underwrite those programs. We would not be able to do that. So I thank them for that.
Okay,
Next
thank
question.
you.
I've got maybe time for one more here because I've got to actually get back. But if you email us questions, we'll get to them as well.
Okay. So in spirit of time, we can just take our last site and go to Pendleton, Oregon, and that'll be our final question. Dr. Aldred has to run back and finish up his day. So Pendleton, Oregon.
Okay, mine's really fast. What pharmaceutical is doing the research?
The research for Duopa or the Rytary?
Yes. What is the pharmaceutical company?
Impax is making Rytary, and AbbVie is making Duopa.
Okay. And then the last question is, if it's being used in Europe and it's proven that it's really working, is the U.S. not corresponding with them on their trials that they've done over there?
Everybody but the regulatory groups is pretty much on board.
That figures.
Yeah, I don't know how else to put it kindly. Well, that was the quick question. We'll take one more from our next site, then a Port Townsend site.
That would be it. Okay, so we'll move to Port Townsend.
Hi, this is Port Townsend. There are 8 of us, and we don't have any questions today. Thank you.
One more then. We'll get to them all maybe. Tenasket. Oh, it's good.
Hi, we hate to make you late, but we have 5 people and a couple of questions. What would you anticipate for the Rytary and Duopa in payment by insurance?
Oh, I think they'll both be covered.
Or Medicare.
Yes, good question. I think they'll both be covered. I really don't know. I mean, they're going to be covered. Rytary is going to be expensive. I suspect that Duopa is probably going to have a pretty good coverage because it's considered a procedure, and we will have documented, because no one's going to use that right off the bat. We'll have documented failure of medication and possibly even DBS contraindication. I mean, with DBS, in Rytary, the front loads are all at the beginning. DBS a little more kind of along the way. So I would think of it kind of like that. I mean, they approved DBS. I think they're going to approve the Duopa they're going to pay for Duopa without any real problem. I don't know what the copay would be. The other thing is that Duopa's got these cartridges. So Duopa is unique because the cost to get a tube put in is going to be really low, but then you're going to have higher costs down the road. So with DBS, the cost is all right up front, but down the road, it's much, much less than even best medical therapy. But with the Duopa pump, you're actually going to have a space in your fridge for a box of Levodopa in gel form because it's sensitive to light. If any of you mix it up right now, sometimes I'll have my patients put it in solution. You have to wrap it in aluminum foil and keep it in the fridge. This is just like a souped up version of that with a month's worth of cartridges in the fridge. So that's going to be an ongoing payment issue that we'll have to figure out, and you have to negotiate with your payers as that changes.
Are you aware of a spoon with a device on it that somehow it measures or counteracts your tremor? They set it.
Yeah, we have one in the office. If you come up, we can show it to you. There's I forget the name of it, but it's about $300, and it's a spoon. It's more for people with essential tremor. Some with Parkinson's have an action tremor. Many don't, fortunately. But I tried it out. It's good for mild, for my fake tremor. Mild to moderate tremor, it works okay. Big tremors, it's not going to touch it.
Okay, thank you.
And then Pullman, I go down to Pullman every other month. So if you have any interest in coming to see me there, I can take your questions, I suppose.
We have 6 people and 2 questions. Quick.
All right.
Does DBS improve balance?
No, usually not. DBS improves if your legs are slow, then that improves with medicine. Usually that improves with DBS. So if that's how if that's the component of the balance problem, then yes. But generally speaking, no. If your meds aren't helping your balance, DBS doesn't help your balance.
Okay, thank you. And second question, are you taking new patients?
You bet.
Thank
I
you.
get up every
That's
morning
it.
to see patients with Parkinson's disease.
Okay, thank you.
Thanks, guys.
All right. All right, and thank you, Dr. Aldred, for joining us today. Definitely a full day. We hope to have you back soon for maybe a repeat as well as additional fun, exciting topics. Just real quick, we missed catching our Walla Walla group. If I could get Walla Walla to chime in if you guys haven't left yet, and how many people you have in attendance.
Walla Walla, there's 2 of us in attendance.
Great. Thank you very much. And I spoke with Cindy earlier at the beginning of the program, and we are still confirming the last-minute details with our March 9th telehealth program, so stay tuned and watch out from information from Cindy about our next speaker presentation next month. Thank you all for joining us, and safe travels home. Thank you.